have Dr. Daniel Dumesic for the endocrine grand rounds today. Dr. Dumesic is professor of obstetrics and gynecology at the University of California in Los Angeles. He is in the division of reproductive endocrinology and infertility. He graduated from medical school from University of Wisconsin, did his OBGYN residency at the University of Minnesota and fellowships at UCSF. Went back to University of Wisconsin as faculty, stayed there for several years, rose up in the ranks, and then went to the Mayo Clinic, where he was professor and was also the chair of the Reproductive Endocrinology and Infertility department at the Mayo Clinic. And he later moved to UCLA, where he has been since 2010. Dr. Dumesic is a well-known clinician, scientist, and educator. He has excelled in all fields, has worked with medical students and fellows and residents throughout his career, has been a very active member of several societies, and has been an author for many of the guidelines, including the guidelines on PCOS for the Endocrine Society. He is his research activities have focused on PCOS, funded through several agencies, including the NIH, and he has over 140 publications, including some of the most highly top-notch, top 10% publications in JCM for 2018 and 2019. So today he's going to talk to us about polycystic ovarian syndrome as a metabolic adaptation. We are very happy to have him talk to us. Thank you.
Well, thank you for that wonderful introduction, and it's been a pleasure so far to be here and talk with the fellows this morning. They're exciting young people, and I wish them all the best in the future. We all see the same problems across the country, so hopefully this will be relevant as we talk. Today's lecture, I'm going to be more scientific. Tomorrow's lecture, I'll be more clinical, so hopefully there'll be a blend of the two lectures together for those of you who can see both of them. But today I want to focus on what we've been doing specifically to try and understand the origins of polycystic ovary syndrome, which has always been a bit of a challenge. And hopefully we're making some inroads in that area. The talk will be maybe only about 30 minutes. I have more to go if we want to go further, or we can stop and ask questions, so I can go a number of different ways with this lecture. I do have some disclosures with these companies, but none of my work with these companies is relevant to our discussion today. And my learning objectives are to basically state a relationship between androgen excess and body fat distribution, to distinguish the relationships of insulin action to subcutaneous versus intra-abdominal fat mass, and then to also explain a programmed effect of subcutaneous abdominal stem cell development that we think is relevant in terms of the origins of PCOS. I know many of you know this already, but as a point of reference, the Rotterdam criteria, which has been recodified in 2018, really defines PCOS phenotypes as combinations of androgen excess, ovulatory dysfunction, and polycystic ovaries, excluding other endocrinopathies. And for our purposes, I'd like to focus on the combination of androgen excess and ovulatory dysfunction, which is now called classic PCOS. It's also referred to as NIH-defined PCOS. And the reason we focus on this is because it alone is the phenotype that's associated with a type of insulin resistance which is independent and additive to that of obesity per se. Now, we commonly see in the clinic, and from the cases we talked about earlier this morning, we commonly see the PCOS woman who comes in with metabolic syndrome. She has a history of obesity, or she is obese. And she has dyslipidemia in combination sometimes with hypertension, insulin resistance, and oftentimes other metabolic abnormalities like NASH and other issues, often related to elevations of free fatty acid in the circulation and profound insulin resistance. And this is what we commonly see in the clinic, in part because this is really where the population has been going in the past 20, 30 years towards a obesogenic environment. The thing that makes these women with PCOS by NIH criteria stand out is they particularly have a type of preferential abdominal fat deposition. We know that all women, and these are studies by Jan Holte that go back several years, all women gain central fat as they gain weight. But at any one BMI, women with PCOS tend to have more deposition of abdominal fat than one can explain by BMI alone compared to controls. Now, these data back from the 1990s were commonly done with physical examination techniques, and so it was always unclear whether women who had NIH criteria PCOS had more abdominal fat if they were lean or if they were normal. And that's very, very hard to study because in today's environment, there are very few people who have PCOS and who are not overweight. So this becomes a tremendous challenge to try and figure out. But we decided to explore it the best we could because around 2011, a paper came out of Stanford by Dr. McLaughlin showing that subcutaneous fat actually protects against insulin resistance while visceral adipose has the opposite effect. And this was a study that she had done looking at insulin resistance where this relationship of subcutaneous fat being protective, where fat should normally be stored, and visceral fat having the opposite effect, was independent of gender and it was independent of BMI. So we thought this might be a novel thing to explore. And so in 2009, we wrote a grant for NIH looking at whether we could figure out body fat distribution in normal weight PCOS women by NIH criteria and understand its component to how we can explain metabolic or reproductive dysfunction in these people. And so this is our 10th year of this NIH grant. And what we've done is essentially was to recruit normal weight women with PCOS by NIH criteria, so they're all hyperandrogenic. We have them matched to BMI and age-matched normal ovulatory women, all from the general community. And so all of these people who oftentimes are students at UCLA are young individuals, often not seeing a physician, and that's what we wanted to do, to recruit them and study them, to eliminate the referral bias in the literature where oftentimes the PCOS patients are studied from clinics and the controls are studied from the general community. So this becomes a huge referral bias that we wanted to eliminate. These women were largely non-Hispanic Caucasian, and the baseline evaluations consisted of a general history and physical examination in our CTRC, multiple hormone and metabolic blood testing that I'll share with you in a moment, a frequently sampled intravenous glucose tolerance test using the Bergman minimal model, and I'll share some data with you on that shortly, and then the combination of total body DEXA and abdominal MRI to sort out body fat distribution, and then finally a subcutaneous abdominal fat biopsy where we could study the fat and extract from the fat tissue stem cells that we could look at to determine whether there are any programming abnormalities that we might be able to detect. Incidentally, all of these individuals, at least the PCOS women, were then entered into a double-blind randomized placebo-controlled trial of placebo versus flutamide at 125 milligrams, so low dose, and all of these studies were done again a second time. So it took a tremendous amount of cooperation on these patients, and those data that I'll share with you towards the end of this lecture have just been published this month in Fertility and Sterility. So about 10 years to get to the answer that we wanted to try and understand. So the abdominal DEXA could be used to determine total body fat, percent body fat. The android fat was defined by L1 to the top of the pelvis, and then we could look at gynoid fat, which was from the greater trochanter to the mid-thigh. And then the patient at the same time at the same day would undergo an abdominal MRI, where we could sort out subcutaneous from intra-abdominal fat, and have the gut fat mathematically removed from quantification. So when you look at these patients that we've collected now, there's 20 and 20, so this again took 10 years to get these patients recruited. Not surprisingly, you see that they have the classic LH hypersecretion in the presence of ovarian androgen, overproduction of testosterone, free testosterone, androstenedione. The female groups are matched by age and BMI, and you'll notice that there's a mild elevation in their fasting insulin, which a trend towards elevated insulin. If you look at their insulin or their metabolic function, I should say, with an intravenous glucose tolerance test, we can calculate a number of things with Bergman minimal model. The two on this slide are insulin sensitivity, which is SI on the x-axis, and the acute insulin response to glucose, which is beta cell function. The PCOS patients are the colored filled dots, and the open circles are the controls. And when you look at this inverse hyperbolic curve, what you see is that the PCOS women are shifted to the low normal range with a reciprocal increase in beta cell compensation function. So people have now stayed on this hyperbolic curve, which keeps them sort of in balance because their pancreas can compensate for their insulin resistance. I would say that when you look at epidemiological studies, what's severe insulin resistance, it's an SI value of under 2. So these people with PCOS, they're just shifted a wee bit. And remember, they're normal weight, they're healthy, they're community-based individuals who happen to be hyperandrogenic and fulfill all of the criteria of PCOS by NIH criteria. So essentially healthy individuals. Now, if you look at, and I can't see, you may not be able to see because I have a figure, my face is in the right upper quadrant of this, so it might be blocking some of the data here. I'm afraid to take it off though. So I'll just talk you through it. When you look at body fat distribution between the female types, body fat, percent body fat are the same between these females types, but the android to gynoid ratio is actually increased in the PCOS women, as one would guess, although recognizing these are normal weight women now that would have been missed by physical examination, measuring waist to hip circumference, for example. And if you look at what portion of the android fat is increased, it's actually the intra-abdominal fat mass, which is more in amount in the PCOS women. And you can also calculate out in vivo adipose insulin resistance per se by multiplying fasting insulin by free fatty acids. And if you do that, this is a trick that the Mayo Clinic has done earlier. That's where I got the idea from. The PCOS women do have an increase in adipose insulin resistance in these PCOS individuals. And we know that both the intra-abdominal fat mass and the adipose insulin resistance both correlate with serum androgen levels and predict decreased insulin sensitivity and increased serum triglyceride levels. These are some of the raw data where we've taken each compartment, the subcutaneous abdominal and intra-abdominal adipose, adjusted for BMI. Even though their BMI is normal, we still put that into multivariate analysis. And you can see that the intra-abdominal fat mass correlates with measures of androgen, lipid production, and also fasting serum insulin, where if you look at subcutaneous adipose, and again, this is where fat is normally stored, it's more a reflection of total body adiposity per se. So this got us interested in looking at the dynamics of these women, because now we realize there is a subtle change in body fat distribution relative to more visceral fat that was linked with these subtle changes of metabolic action, particularly insulin resistance and some elements of lipid levels as well. So what we did is we took out the stem cells at the time of biopsy. You can separate them from mature adipocytes. And the first thing we did is we looked at their transcriptome to see what was happening. And the first studies we did, and these date back to around 1912, or 2012 rather, you can see that the genome is abnormal. It's different in the PCOS stem cells because there's overexpression of genes that are favoring lipid metabolism, and with the key master gene being TGF-beta1. So we were suspicious that they might function differently, and therefore Dr. Chazenbach, who's worked with me at UCLA over these years, developed some techniques that we could study with small amounts of stem cells to grow the stem cells out in adipogenic media to drive them to newly formed adipocytes in vitro. And the way you can do that is with cocktails that first take a stem cell and drive them through a commitment phase to become a pre-adipocyte as opposed to cartilage or muscle or something else. That can be measured with zinc finger protein 423 over the first several days of cell culture, and then over about 12 to 14 days, you can look at the differentiation phase of the pre-adipocyte as it becomes a mature adipocyte, and you can measure that with lipid content with immunofluorescence. And what you see here is that the PCOS stem cells, again the colored circles, have an exaggerated drive towards pre-adipocytes in the commitment phase, and then once they commit, they have an exaggerated lipid accumulation that occurs as they grow out. And I want to remind you that these are cell culture studies done in the absence of androgen. So we're trying to study them in their kind of native form, if you will. Here's a picture that kind of shows how they look. You can see on the right side, the PCOS stem cells are chock full of lipid. These are these red blobs of lipid. The control cells, stem cells that have been studied at exactly the same time have much less lipid accumulation. So the immunofluorescence studies actually go along with our thoughts on this exaggerated lipid accumulation. During this time, we were wondering, well, is this related to testosterone? Is this related to something else? So we started with some methylation studies on these stem cells as they grew out to adipocytes. Didn't see too much there. Then we went to chromatin studies, ATAC-seq technology, looking at how the chromatin opened during these stem cells as they were cultured. In this slide, the little pink dots below the line of unity are the PCOS stem cells, and you see that on day 0 when we obtain them, the chromatin is very, very tightly wound compared to controls. And then as they grow over several days up to day 12, the chromatin actually opens up in a very expansive way, more so than the control stem cells. And if you study the open sequence of the chromatin, it actually shows motifs with high homology to superfamily member transcripts of AP1, which drives lipid accumulation. Now, we were expecting it to be related to androgen, but it was related more to transcription factors that were driving adipogenesis, which is the formation and transition of a stem cell to a mature adipocyte. This told us there might be a programming phenomenon here that's independent or maybe related in part to androgen, and I'll get back to this phenomenon in just a little bit. But the next thing we wanted to know was, what is the relationship of this exaggerated adipogenesis, if you will, in both commitment and differentiation to translational effects of the clinical data of the patient at the time we obtained the fat biopsy. We had all of these tests done at the same time, so we could correlate them to clinical medicine. The first thing we found was that again with the stem cells of PCOS women being in the solid circles, the expression of zinc finger 423 protein as a sign of commitment was inversely related to their fasting glucose levels. So this we interpreted as a benefit for the balance of metabolic function in these individuals. When we looked at lipid content, the lipid content was related to free testosterone level. And when we looked how the lipid content correlated with clinical outcomes, we found that in the PCOS stem cells alone, but not the controls, that as the lipid content increased, the free fatty acid levels in the circulation reduced with an improvement in adipose insulin resistance because free fatty acids is part of the equation, and the insulin sensitivity by the glucose tolerance test actually improved. So both the commitment of these stem cells towards pre-adipocytes and the exaggerated lipid accumulation in these adipocytes of PCOS women were actually favorable in terms of presumably encouraging fat storage where it should be stored and sequestered away from the circulation. So we viewed this mechanism of stem cell differentiation as a benefit in the PCOS women. Now, around this time, Dr. OReilly had come out and had started with a paper that was looking at local production of androgen in the subcutaneous fat. And these are known as a family of aldoketose reductases. There's a specific enzyme in this cascade of enzymes that controls body fat distribution. And the one in particular is AKR1C3, and this promotes the conversion of androstenedione to testosterone with higher activity. And this enzyme is particularly prevalent in subcutaneous fat versus intra-abdominal fat. He had shown that AKR1C3 mediated testosterone generation was both increased in the subcutaneous abdominal fat of overweight and obese PCOS women, in whom it increased lipid formation and decreased lipid breakdown or lipolysis. And his theory went something like this. If you have local amplification of androgen action in the subcutaneous fat through AKR1C3, you are going to drive fat storage in the subcutaneous compartment through enhancing lipogenesis or fat formation and by blocking lipid breakdown or lipolysis. This would drive increased abdominal fat mass in the subcutaneous tissue, which when reached a capacity would result in overspill of free fatty acids into the circulation, which would drive hyperinsulinemia. And in his model, he had shown that insulin induces AKR1C3 in a feed-forward system. Now, we are interested in this model in part because others had shown that in normal subcutaneous fat tissue, androgen impairs the ability of catecholamines to induce lipolysis. So it blocks lipolysis through catecholamine action, and this is mediated through the beta-2 adrenergic receptor system. If you look at fat tissue of PCOS women, and these were studies done by Peter Arner and others, it has the same phenotype. So we are suspicious that androgen does play a role in fat storage in the subcutaneous compartment, and therefore we were interested in exploring this phenomenon of what's known as metabolic inflexibility, or what the equivalent is of lipid sparing. This has been shown in obese girls through measurement of glycerol as a measure of glycolysis. And you can see in the PCOS women on the left, these are young adolescent girls who are obese with PCOS. Their glycerol levels are low, as well as their beta oxidation levels are low. And then Dave Abbott, working with Lena Wiggum, studied overweight PCOS women. They were able to separate out metabolism of fat from that of glucose and protein by looking at the differential effects of carbon isotopes on fat versus the other two moieties. And in the picture on the right, the blue trapezoid is the metabolism in normal women of protein and glucose throughout 24 hours. And what you can see in the morning hours is that it goes down because it's replaced in the morning hours by beta oxidation of fat, which is not measured with this isotope. But PCOS women stay even Steven all the way across. So in the morning, they keep sparing fat and burn other energy substrate, going along with this fat storing effect that, that Dr. OReilly had talked about. So we took our stem cells, again, of normal weight women, grew them out again, and this time, along with the lipid accumulation, we also tapped in and looked at the gene expression of AKR1C3. And what we found was that the lipid accumulation, which again has this exaggerated accumulation over time, was paralleled by a concomitant increase in AKR1C3, suggesting that some of these mechanisms that Dr. OReilly had talked about might actually have their origins as these stem cells start growing into adipocytes during the normal adipose turnover, adipocyte turnover that takes place. Now, we didn't have the tools at the time to take the fat tissue and actually measure AKR1C3 in it. But the next best, and perhaps not the very best, was to measure the ratio of total testosterone to androstenedione in the blood as a marker of AKR1C3 somewhere in the body, because it is present in other tissues as well, including the liver. And much like the stem cell clinical data of the translational effect, we see that as the ratio of T to A4 goes up, again as an indirect marker of this enzyme, we see that the fasting triglyceride levels and adipose insulin resistance actually go down, arguing that perhaps as you slow the turnover of triglyceride through proper fat storage, you take the edge off of adipose insulin resistance, which again would go with a beneficial effect of fat storage, assuming you're in the range where you have enough fat to store if you're lean and otherwise have some flexibility in your subcutaneous adipose compartment to store fat. So that led us to our recent study, which we've just published now. And what we did now, and COVID affected things because there were a lot of dropouts and things that took place along with COVID, and this was present in a lot of the clinical studies at NIH and I'm sure others. But now what we did is after 6 months of the PCOS women being randomized to either flutamide or to placebo, we now did all these studies again and said, what changed relative to their clinical data and their stem cell data? And what we found, not surprisingly, was that the women who were, these are all PCOS women, but those randomized to flutamide had a reduction in android fat mass. That was not a big surprise. That's been shown before in larger amounts of flutamide. We used only 125 milligrams because it was deemed to be the safest. We didn't want to get caught with any liver problems with these study patients. So the NIH asked us to come in with as low dose as we could, which we did. But still we had this reduction in android fat, which was anticipated at higher doses. And that was associated with some improvement in LDL and non-HDL as well. So these were not surprising data. But what was surprising, or maybe not so if you reflect back on the chromatin data, is that if you look at the lipid accumulation in individuals who were studied with flutamide, so this is basal and after 6 months of flutamide, yes, you see a reduction in the lipid content during their growth in cell culture, so that was good. But what I found more important, or maybe more interesting to me, was every one of these studies was the PCOS woman was matched with a control. And so we could normalize her lipid content to the control with a unit value of 1 if there is total reversal of the lipid content. And what you can see is, although the flutamide has an effect, the stem cells stay abnormal. They do not go back to a unit value of 1. So either the dose of flutamide was too low, which is one possibility, although in clinical medicine there's been arguments that, at least in skin, that flutamide does not have a dose-dependent effect. Or it could be that the chromatin that opened up abnormally along transcription factors of the AP1 superfamily are really an independent phenomenon and therefore programmable. And so this led us to our current interpretation of the data. And this is our big picture thing. So I'll just share with you what our thoughts are. We think that the intra-abdominal fat is more prevalent in mass, even in normal weight hyperandrogenic PCOS women. And this is associated with a slight reduction in insulin sensitivity related to androgens and a slight increase in triglyceride levels, although not necessarily in the abnormal range. In the subcutaneous compartment, you have a storage phenomenon going on, which is proper and driven by local amplification of androgen by AKR1C3, and this is associated with an improvement in insulin sensitivity. And this is further fostered by stem cells, which are doing essentially the same things in a way by offering new adipocytes during turnover to do that same sort of protected phenomenon. And so what we see clinically is this combination of the increased android to gynoid ratio associated with a slight reduction in insulin sensitivity and a reduction, or an increase, I should say, in adipose insulin resistance. So one can say, well, why is this the case? And so we think that this could represent a metabolic adaptation in PCOS that balances fat storage with glucose utilization in critical target tissues, but predisposes to weight gain and lipotoxicity in today's obesogenic environment. We do see a lot of people, as we've heard of the fellows talking today, with people coming in with PCOS saying they just can't lose weight. And maybe there's some truth to that goes beyond lifestyle modification. So when you look at PCOS from an evolutionary genetic standpoint, and others have done this. Andrea Deneff, I'll probably show some of her work tomorrow when I give the grand rounds to medicine, which is much more clinical than today. The idea that there's several genetic routes into the phenotype of PCOS through the GWAS studies that have been done. But this goes along with the idea that the PCOS phenotypic expression that we know of is likely the product of several different genes amongst the various populations that interact with environmental factors. And one could argue that this could have its origins earlier in life during hunter-gatherer communities in which environmental stress favored the survival of individuals who had the greatest capacity for fat storage to endure these episodes of starvation, or this kind of idea of a thrifty phenotype. And so people have argued, and I know Ricardo Aziz has made this argument years ago too, if people had a little, if people had a little bit of PCOS, then you could balance this energy storage with glucose availability and fatty acid oxidation for reproduction, particularly during times of famine. And if one ovulated less often, childbearing would probably have fewer offspring that would enhance the survival of the offspring. And yet in today's environment, this now works against the patient because this is essentially a signal to store fat, which would lead to lipotoxicity or pregnancy complications in today's obesogenic environment. The people who have argued against this have said, well, but PCOS is a human disease and there is no model for that in nature other than these manipulations that have been done in rodents, monkeys, sheep, and others. So when this happened and this debate surfaced, Dave Abbott and I thought, well, let's go back and study the normal population of rhesus monkeys at the Wisconsin Primate Center that we've studied for all of these years. So these are all normal, quote, normal monkeys. What Dave did was to go back, and of course all these animals we have blood samples on and records. And so he measured testosterone levels in the whole animal colony and divided the normal animals into high normal testosterone, which is over 1 standard deviation above the mean, versus the others. And then they went back in their records and said, well, what was their menstrual cyclicity like? And when they were mated in mating studies, what was their fecundity like? And what they found was that those individual animals that were controls that had high testosterone levels, with the arrows showed a high degree of menstrual irregularity, and those that were mated had a high incidence of being non-parous or not conceiving during the studies. So this has led us to believe there is a naturally hyperandrogenic animal model for PCOS. It's the primate system. It's the rhesus monkey. And we think in that sense, you could make an evolutionary argument for this. What I've done now is this has been 30 minutes, and I just wanted to offer recognition of the support of NIH and the Santa Monica Bay Women's Club that's been with us on this journey ever since I came to UCLA. And I would like to also acknowledge all of the people that have helped us. We have a big student program of undergraduates that's done some of the work that I shared with you today. Vasanta Padmanabhan is one of our colleagues at the University of Michigan. Dave Abbott, that many of you know, is at the University of Wisconsin. And Gregorio Chazenbach joined me when I came out to UCLA and is the head of our directorship, although we've worked with Dr. Stauffer and John Hennebold at the Oregon Primate Center as well. But I wanted to stop now, and I can keep going and show you other things, or maybe it would be fun to just stop now and see if you have any thoughts or open it up to discussion. And then this would be the event code that you would use for your CME credit. So I'll stop right there and open it up. I see Steve has kind of chimed in, but I'll take any questions you have or continue as you wish.
Okay, we can start with some questions about this in terms of, so when you looked at these individuals, so these were mainly lean individuals or non-obese PCOS, correct? You know?
That's correct.
So what are the obese PCOS just the more severe phenotype of this, or are they totally different?
Well, we think it's a continuum. What we think is happening, and kind of make it simplistic and then maybe throw something else we're working on right now, is that if they're shifted towards this lipid-sparing phenomenon with a little bit of insulin resistance, then according to Dr. OReilly, as these women would gain weight, then they would eventually exceed the capacity of their subcutaneous fat to store fat. This would bring free fatty acids into the circulation with deposition of free fatty acid in other tissues like muscle and visceral. And this would now, with a continued increase in intra-abdominal fat, because intra-abdominal fat is highly lipolytic, would drive more free fatty acids to the liver, which would lead to fatty liver and progressive insulin resistance. So we think it's a continuum. What we're exploring now, and what we put in for Endocrine Society, I don't know if it'll be accepted or not, is we're trying to link this whole phenomenon with adrenal androgens and cortisol, because there's an adrenal story to this as well that we have to explain, and we think we have an explanation for that too, but that's something we're working on right now.
So having worked with Sarah Berga some years ago to show that in thin PCOS women that the increased frequency of LH secretory episodes is so dramatically elevated, I've always been interested in the question, is that a primary event or is that responsive to something else? Of course, John Marshall's really pioneered the idea that that might be androgen dependent. So later I'll look at your paper and see what happened to LH after flutamide. But let me make a couple comments. First, in my work with Tony Plant, we found that monkeys make much, much more SHBG than do humans, at least 4 times as much. They have very little body fat, and we thought it might be that, at least in males. And you can't measure the SHBG with the current ELISAs because the genetic structure of the SHBG is different in monkeys than humans. So we had to use a binding assay. So in your work with Dr. Abbott there on the T levels, when measuring total T, think in the back of your mind that maybe there's a dramatic relationship between SHBG and body composition, and that might be interesting, something to think about. So, so the high LH, so getting back to that. So some years ago, we had a colleague here, C.V. Rao, and he worked with Dr. Lee there in our OBGYN group, and they showed that LH receptors are present in lots and lots of other tissues other than in the ovary. And one of them was fat tissue. So I'm curious as to whether your enzyme activity of the AKR is somehow dependent on the LH drive to the fat cells. So I wondered if you thought about that.
Yeah, we thought about all of those things, and they're all excellent points, Steve. So thank you for all of them. I'll start with the human stuff first, I guess. We thought maybe LH might drop with flutamide because that had been shown. And we were worried about that because that would be a covariable we'd have to block for. And with such limited students or subjects, we would have a hard time doing multivariate analysis. The LH did not go down. And we don't know if that's just because it's flutamide 125 milligrams. The ones where flutamide did drop LH, you're talking 250 milligrams, 2-3 times a day. So at least that wasn't going on. In terms of HCG, excellent point that those receptors or LH receptors are in fat. There was a HCG craze not too long ago for people to lose fat. We have not explored that, but that's certainly within the realm of possibility. That has not been explored, at least to my knowledge. In terms of the LH hyperactivity, yes, Chris McCartney and the group there with John Marshall did show that flutamide did reduce LH. But interestingly, now there's some new data coming out from Tata on AMH, because in his model, this goes back, I think, to a rodent model. This was published a couple of years ago. AMH appears to, receptors are in the hypothalamus. It appears to increase LH pulsatility, to my knowledge. And this was by injecting recombinant AMH into pregnant rodents. And he made the pregnant rodents hyperandrogenic by injections of recombinant AMH. AMH receptors are also present in the placenta where they suppress aromatase. So now a new theory is out. I'm not so sure I buy it, but I think it's on the table, that pregnant women, PCOS women who have high AMH levels could theoretically drive LH hypersecretion in pregnancy, even though you would think it would be totally suppressible, and offer a way to drive the androgens in the mother directly into the fetus through inhibition of aromatase, and therefore program the fetus through maternal androgens rather than our theory of metabolic dysfunction in the mother programming the fetus. So I think the story on AMH and LH, that's one that's going to play out, I think, probably in the next few years. In terms of the body fat on the monkeys, point well taken, SHBT2. As you probably know, Dick Stauffer and John Hennebold have been trying to work with these androgenized adolescent monkeys, where they randomize them to obesity, testosterone, and the combination of the two. boy, it's hard to get subcutaneous fat on these monkeys. They're just not there. And especially at birth, can't even study it. So yeah, those are profound limitations of the animal model. Good point.
So there's a question here on the chat. Do you have any interest in studying other animal models?
There are several out there. Matter of fact, there's one that I saw that might be presented at Endocrine, a new guinea pig model people are working with. The models out there that have been used a lot, the sheep has been used a lot. The reason why Vasanta Padmanabhan likes the sheep is the sheep and the monkey model both are programmed in utero. So that if you're looking at programmable effects during fetal development, only the sheep and the monkey model really fit that category. The rodent model, a lot of programming occurs after birth. So now you're left with various rodent models to work with. Each one has its good, each one has its kind of bad. Each model has its own challenges. The letrozole model is a bit of a challenge because if you try and knock out aromatase to drive up testosterone to program the animal after birth, you so lower the estradiol that sometimes you're left wondering, well, is it the paucity of estradiol or is it the elevation of testosterone that's causing the programmable event? The model that I sort of thought was interesting in the rodent realm is the low-dose DHT model. That's just a twofold elevation of DHT through a capsule that they put, I think, in the shoulder blades. But it's enough to change some of the aspects that they're studying, but not induce obesity, at least when they do MR studies. So that it's a way to kind of separate out the obesity story from the testosterone model without kind of bollocksing up the estradiol too badly. So I think out of all of them, in the sheep model is another fetal programming model, which is good. There's good and bad to it. The monkey model, for the same reason as Dr. Winters mentioned. And then I guess my personal favorite in the rodent model is the low-dose DHT model, because you can try and separate out obesity from other effects of androgen per se. There are actually androgen knockout models too, now that I think about it, that have been used in Australia and other places. And I think those with the selective knockout of various target tissues are also very helpful too. So I think there's a few ways to take the rodent model forward.
So one of the things is, we often recommend these individuals with PCOS, especially obese ones, to lose weight. Does that change any of this?
Yeah, if you looked at strategies to lose weight, perhaps the greatest one is bariatric surgery. You can reverse a lot of this. Now, you can reverse it. That doesn't mean the programming signal went away. It means you reversed the phenotype. Now, tomorrow we'll talk a little bit about the GLP-1 receptor agonists. Same there. You drop, your percent body weight about 6% or thereabouts. People start ovulating again. Metabolic dysfunction improves. Lifestyle as well. You can go all the way down the spectrum. I mean, each strategy has a different success rate. But if you look at people who are successful, you can reverse the phenotype, and so does age, because as women get older, their antral follicle number drops, and as their antral follicle number drops, their testosterone level drops, and because the 5-alpha reduced androgens in the ovary inhibit aromatase, they start ovulating again. So just yesterday, we had a woman who came from Harvard. She's a lawyer out in LA. We worked her up. We did a whole workup, the big shebang, and we came up with, you have non-hyperandrogenic PCOS. Your androgens are normal. You have menstrual irregularity. You have polycystic ovaries. That's what it is. And then she said, would you mind reading my all my correspondence and labs from Harvard when I was there in 2007? I said, sure, happy to look at it. So she sends me, it had to be 50 pages of labs. And by God, and they did everything exactly right. Her testosterone was very, very high, and she had the NIH phenotype of PCOS, hyperandrogenic, and now I'm seeing her in her 40s. So, and that's been reported in the literature quite a bit. So as you get older, you can flip your phenotype because you drop your androgens somewhat because your antral follicle number is diminishing. So there are ways to change it.
So Dr. Wesley Wynn, who had asked the initial question about the animal model, there's another question here. Have you considered taking or examining anthropologic records of ancient humans or even extinct human relatives?
I would love to do that. I would love to do that. I think the only guy who's actually tried to look into that, and not exactly at that endpoint, but is Ricardo Aziz. He's actually went back and looked at some of the data on the Egyptian mummies and the CT scans that have done on them, and looked at coronary artery calcification and things like that. There actually was a very high incidence of cardiovascular disease in these people. They didn't live very long, but much like our studies at the Mayo that I'll share with you tomorrow, even in the 30s, there's a lot of coronary artery calcification there. So to try and get down phenotypic expression and body fat distribution, other things in a mummy would be a little bit challenging, or maybe through records. But I think if you buy the argument of evolutionary adaptation, you would believe that it had to be around a long time.
So we also have a group of researchers here in the GI department who are interested in organic pollutants, things in the environment. So there are some studies about various organic compounds, including polyphenolalkylanes, PFAs, which have been linked to insulin resistance and to PCOS. Do you know anything about that, and have you thought about it?
I've thought about it. I know a little bit about it because the person who spent a lot of time looking at this and still is Vasanta Padmanabhan. She's focused on bisphenol A. And there are metabolic perturbations that are programmable in her sheep model. And again, the sheep model is of value to us through her because programming events occur in utero. So she's been able to show that, and I think she was one of the people many years ago who was really instrumental in banning bisphenol A in states and things like this. In terms of dioxin, years ago, it was linked with endometriosis in monkeys, if I'm not mistaken. So those are the two that come to my mind. I think the literature, when I try and read it, and I think Linda Giudice's, looked at this a little bit, in the real world, everyone's exposed to like a bunch of them together. So there's probably some interactions amongst all of them that affect our environment, as opposed to experimental designs where you take one at a time and you say, what does this do? What does this do? And then, well, what's the epidemiology of some of this environment we live in where there's all sorts of things we're exposed to day by day? But that's my limit, Dr. Winters, of my knowledge of that subject, but I'm sure it's greater than that.
So another area that has also been looked at, especially in obesity and insulin resistance, has been, and they have talked about it with PCOS, is about the microbiome. Okay. So what is that, how does that play into this?
Well, it may, the work that came out of San Diego and other places now where this goes to rodent models because, as you know, rodents are, caprophagic? They eat stool. So what you can do is you can do these stool lavages, and you can transfer them through an NG tube into different rodents and, alter their bio. You can take one animal and develop an abnormal microbiome with testosterone, and then you can take that stool and you can feed it to a normal animal and see if you can replicate the phenotype, and they can. So there's something to it. The data on interpretation, again, I'm not the expert, but I'll tell you what I know, is when people look at the microbiome, it's not just one simple thing. It's a shift in the diversity of the stool. So it's not like one thing. It's a shift in this diversity towards, I think, Firmicutes is one of the bacterium. There's another one by an odd name that I'm blanking on, but it's the shift of many bacteria in certain families. So it's kind of like epidemiology relative to some of these toxins. There's all sorts of combinations occurring and shifting together. The problem, if you look in the literature, you can see in these animal models, if you take out the small bowel, if you stretch it on a strain gauge, and if you put it in a solution bath to see if the junctions of the cells are intact or not, you can disrupt the junctions, and that's the idea of how you can transmit some of these lipotoxins and polysaccharides into the circulation from the gut. The gut gets, quote, leaky. The problem I have with the data, personally, is that you're studying twofold. You're studying the colon, you're not studying the small bowel. So what does the colon stool have to do with the small bowel where the leaky gut should be taking place? And number two, there's some recent data out of one of the colleges here in California, where if you control for the pH of the stomach and look at the microbiotics that you can take, very few of them make it through the gut into the small bowel where things should be happening anyway. So what's the management of this if you can't get anything to the small bowel? There's some clinical questions that become relevant. So I think something's there. People have looked at that. I think it's something to consider, but how that fits in, I think that's still a story that's being written now.
Any other questions? We're almost at 5 o'clock.
I had one question for Dr. Winters. Is he playing guitar?
Yeah, I still am. Can you see it behind me? No, I put it away in my case this morning because we had our housekeepers here.
Oh, okay.
So very often it's right behind me. But that's an amplifier. If that's what do you see the amplifier?
Yeah, I saw the Fender.
Yeah, that's my amplifier. Yeah, right. 1964 or so.
Oh,
still, it's a very, very fine piece of work.
I have a question in the chat box.
Oh, okay.
It's about abnormally high testosterone and its impact on certain cancers like prostate cancer.
Wow. Okay. Well, prostate. So I'm not so sure I can speak too much about prostate since PCOS women don't have one. I can talk a little bit about, I can say a few things, maybe a little bit flight of thought here a little bit. When we have super high testosterone levels, and we're seeing that more and more, by the way, also in perimenopausal women, the first thing we do is we say, is there, on physical exam, is there evidence of virilization as opposed to hirsutism? So we start looking for signs of masculinization and defeminization. And we measure the clitoris because that's oftentimes the first thing that changes. So you can actually measure that. And if it's enlarged, you know that androgen has to be high. Years ago, there's this cutoff of testosterone. If it's over 200, you should think about tumor. Well, although that's true, we see tumors below that and we see hyperthecosis above that, which is not tumorous. So we use virilization to decide what to do in terms of ruling out tumor, and oftentimes the testosterone is high. The Sertoli Leydig cell tumors in young women are easy to see. They're very inefficient tumors, so they're always big. You see them, they're 4 centimeters. The adrenal tumors you can see as well. The challenge is the Hyler cell tumors in the postmenopausal women because you can miss them, even by MRI. So sometimes you have to go in and you have to loop out with a laparoscope the ovaries, but a lot of times people don't want to do that. We have seen it improve with changes of their metabolic dysfunction, because we know insulin is a cogonadotropin and will drive that theca cell. The theca cells don't go away, when you're menopausal. The granulosa and the follicles do. So a high level of insulin in a diabetic perimenopausal woman, that'll drive up her T. And so sometimes we have to take these out, and we see hyperthecosis. So we see that in the stroma are all of these, I think they're called Rentge crystals, which are just signs of profound steroidogenesis. Relative to prostate, I don't know too much about that, but I do know that people like Rick August and others are looking at some of these prostate cancers that are escaping treatment by GnRH analog, and whether that's related to some of these enzymes that are locally amplifying these androgens and target tissue we've talked about, I don't know. So I would have to kind of plead ignorance to that. I just can't answer that for you. I'm sorry.
Thank you very much.
Thank you very much. So we're very glad to have this wonderful talk, and we look forward to your talk tomorrow.
Okay, wonderful. And I think we'll be talking again shortly, just amongst some of the
Yeah, it's a different link, I think, that she set up.
Okay, I'll move to that soon. Dr. Winter, it's nice seeing you again.
My pleasure. I wrote that paper about the decline in testosterone with aging and PCOS together with Dr. Evelyn Talbot in Fertility and Sterility somewhere in the 90s. That came from a study that they were doing on the cardiovascular outcomes of PCOS patients. So they were collecting hormone determinations in PCOS women across the age spectrum. And my job was to measure the androgens, and lo and behold, it was just what you said. So
wow. Well, you're a rock star in many ways.
I think that paper is one of my most highly quoted papers, even though my work has really always been in males. I went in the back door on that.
Oh man, that's awesome. That's very impressive.
It was just part of their study.
Oh my God.
An adjunct, if you will.
That's fantastic. Well,
that was a great talk. It's great to hear people coming at the PCOS story with new ideas and new directions. I mean, it's suffered from Brownian movement for a very long time, and we really don't know what the basic cause of it is. And, with a little luck, you're in the right direction. I hope so.
Well, fingers crossed. Thank you for the encouragement.
You bet. See you tomorrow.
See you later.
Okay.